Welcome back, Roundtable listeners. This is John Fralick, one of your hosts. It's the holiday season, and so we're taking a little break from releasing new content. But not to worry, we have an excellent throwback episode for you today when Mike interviewed Dr. David Juurlink about some of the top 5 drug interactions that we often overlook. We'll be back with some new content next week. Thanks for listening, and Happy New Year.
Nobody cares, right? No one's going to die. The gastric pH is not going to go to 14 and eat a hole through their abdominal wall. There's no harm from this. But if the patient's on a calcium channel blocker or immunosuppressant or a sulfonylurea or a statin or a DOAC or warfarin, those are drugs that you don't want to mess with.
This is The Rounds Table. All right, welcome back, listeners. I'm excited to be joined today by Dr. David Juurlink. He's the head of Clin Pharm and Toxicology at Sunnybrook here in Toronto and professor of medicine at the University of Toronto. He is also a senior scientist at ICES and medical toxicologist at the Poison Center. Fun fact, he's the reason I got interested into pharmacoepidemiology back when I was in R1. Dave, welcome to the podcast.
Happy to be here.
Well, Dave, I was just on service and I saw a patient who was on warfarin and getting some Tylenol, and it reminded me of drug interactions that you've shared with me from years gone by that I definitely would not have known otherwise. And I'm hoping over the next 20 minutes, you can share some of these pearls. Maybe we start with, what is a drug-drug interaction, and then dive through some classic examples and mitigation strategies. Does that sound okay to you?
That sounds perfect. Yeah.
All right. Well, Dave, fire away then. I'm all ears, and I'm going to try to remember and synthesize.
What is a drug interaction? So I think, to be a bit tongue-in-cheek, a drug interaction is the sort of thing that makes doctors' eyes glaze over, and they just hand the baton to the pharmacist and ask them to sort it out. And that's sort of understandable because it's a really complicated area. But a drug interaction at its core can be described as a clinical occurrence where one drug alters the response to another drug. It's as simple as that. And I think I often underline or emphasize the word response because I think of most of us, when we think about a drug interaction, we think about a scenario where a patient's on one drug, and if you were measuring the concentration, it's in a certain therapeutic range, and then you add a new drug, and the concentration of the original drug goes up and maybe causes toxicity, or goes down and causes a loss of effectiveness. That's sort of the prototypical drug interaction. When that happens, we call that a pharmacokinetic interaction. And I know that word kind of drives people crazy. It's boring, but when one drug changes the concentration of another in the blood, it has to be because that new drug has tinkered with one or more of the absorption or distribution or metabolism or elimination of the drug. That's why we call it a pharmacokinetic interaction. But that's only one kind of interaction. You can also have interactions where drugs don't change concentrations at all. You have drug A is on board and then drug B is added and something bad or even fatal happens, even though no concentrations have changed. And so a good example here might be opioids and alcohol, right? A person's taking opioids for chronic pain. They're on, let's say, 40 milligrams of oxycodone twice a day. And then they drink too much alcohol and take a sedative at bedtime and they don't wake up. That's a pharmacodynamic interaction. And pharmacodynamics is just that branch of pharmacology that deals with what drugs do to people, as opposed to what people do to drugs, like the absorption and so on. So all drug interactions can be classified as either pharmacokinetic, if the new drug tinkers with the kinetics of the first drug, or pharmacodynamic, if they do similar or sometimes opposing things at, say, the receptor or cell level. So that's probably an unnecessarily long answer, but that's in general what a drug interaction is. And I guess I should make the point that there's like thousands of these out there, like literally thousands of interactions. And so it's one of these aspects of medicine and pharmacy practice that even the most diligent, invested clinician just can't keep on top of. It's very, very complicated. And so it's easy to tune out on that basis alone.
Yeah, I think we can all agree to that. And no matter how many times I learn pharmacokinetic, pharmacodynamic, I have to relearn them. So hopefully this time it will stick. So in terms of really bringing this to life, like what are some salient examples that the listener might not be aware of, and maybe we should be?
Well, I mean, there's a rather large list to pick from. Let's take the Tylenol and warfarin that you mentioned at the outset. We don't see quite as much warfarin now as we did, say, 15 years ago since the DOACs have taken over. I mean, we still see people on warfarin from time to time. And I think it's an important interaction to be aware of because people are oblivious to it. Not oblivious, but it's not widely appreciated. And it's also not widely appreciated that people can die from this. And so the TLDR here is that adding acetaminophen to warfarin can cause a rapid and often substantial increase in the INR. And to understand why that happens, they have to first understand how warfarin works. Now, we all know that warfarin's a vitamin K antagonist, but what that means in the simplest terms, I'll put it like this. We all know that the vitamin K dependent clotting factors are 2, 7, 9, and 10. Let's take 7 as an example. 7 doesn't do anything. None of them do anything. They have to be converted into their active form. 7 becomes 7A. And that process involves an enzyme called gamma carboxylase. Doesn't really matter, but that enzyme essentially attaches a carboxyl, a C double bond OH, to the protein and turns factor 7 on. So that enzyme, gamma carboxylase, uses reduced vitamin K as a cofactor and uses it up. We run our coagulation cascade in part because we recycle vitamin K. I'm getting very deep very quickly here, but the point is that warfarin works by interfering with the recycling of vitamin K. Normally, this used up, oxidized vitamin K is no good to us. We have an enzyme that regenerates it, makes vitamin K great again, if you like. And that enzyme is called VKOR, VKOR, and warfarin turns that enzyme off. So when you've got a patient on warfarin whose INR is 2.5 and everybody's happy, it's because you've inhibited that VKOR enzyme just enough to deplete the patient of reduced vitamin K just enough to compromise the activity of gamma carboxylase, just enough to lower your factor 7A, just enough. It is kind of detailed. That's how warfarin works. Tylenol, when you drop Tylenol into this mix, Tylenol's metabolite, the same one that will trash your liver if you take 100 tablets and wait a day to come to hospital, is made in small amounts with standard doses of 2, 3, 4 grams a day. And that metabolite is like throwing a small bomb into the vitamin K cycle. It essentially potentiates warfarin at multiple spots in its activity. And so what we see clinically is the person's on warfarin. Actually, the most common scenario is a person who's got an unexpectedly high INR. INR is 8. Maybe it's just a lab value. Maybe they've come in with hematuria or something like that. And they haven't changed their dose and nothing is different. And they haven't changed their diet, but they've been taking for the past several days, 3, 4 grams of acetaminophen for fever or whatever. And so that's an important interaction to be aware of because everyone listening to this podcast has acetaminophen in their medicine cabinet. Everyone with warfarin's probably got it in their medicine cabinet too. We just don't think about it as a trigger of drug interactions. But in patients with warfarin, it can happen quickly and it can happen at standard doses of acetaminophen, and it can occasionally even be fatal.
Yeah, and I feel like it's the severity and the fatality and the fact that we see warfarin so infrequently. I don't think we're attuned to be thinking, oh, and maybe this innocent acetaminophen Q4H, half a gram is going to do anything bad. Half a gram. Yes, half a gram, 500 milligrams. So, okay, so that's first up. We got acetaminophen and warfarin. Beware of that. Do we want to stay in the blood thinner category for other drug-drug interactions or drug interactions to discuss, or where should we go next?
I mean, I guess we could. The DOACs don't interact with acetaminophen. And again, I guess here the main ones, we don't see so much dabigatran anymore.
Thankfully.
Yeah, thankfully. I'm still kind of amazed that that drug made it as far as it did. So I guess I would say, let's not talk about dabigatran. Let's talk about, say, rivaroxaban and apixaban. They get a fair bit of use. So those are drugs that are susceptible to, actually, let's go back to pharmacokinetic and pharmacodynamic, not to bore people. But if I told you that the patient was on apixaban and they were also on aspirin, that's a drug interaction, right? Aspirin doesn't change apixaban's drug levels, but if you knock off phase 1 hemostasis with an antiplatelet and phase 2 hemostasis with a DOAC or warfarin, and there are sometimes you have to do that, but it shouldn't come as any surprise that the risk of bleeding goes up. So anything that alters blood's tendency to clot and in a patient who's on an anticoagulant is obviously going to have a pharmacodynamic interaction. The more interesting ones, I would say, are the pharmacokinetic ones, the drugs that can change the concentrations of, say, rivaroxaban or apixaban. Let's take Riva as an example, or let's use apixaban. I think we see more of that these days. If I gave you a drug that enhanced the metabolism of apixaban, your apixaban level would fall and your protection against stroke and systemic embolism would also fall. And the best example here is rifampin. I mean, we don't use a lot of rifampin, but boy, rifampin is just a nightmare when it comes to drug interactions because it induces a whole series of processes. So rifampin induces the liver enzyme that metabolizes apixaban and rivaroxaban, and it also induces a pump called PGP, or P-glycoprotein for long. This is a pump that normally influences our absorption of and our renal elimination of DOACs. If someone comes in on apixaban or rivaroxaban and you put them on rifampin, their level will plummet. So that's a good example of a drug interaction you just have to avoid. Like in that scenario, you just change them to warfarin, I suppose, right? Because you're not going to want to use a strong inducer of CYP3A4, the enzyme, in that scenario. Another drug that does that, carbamazepine does it. More commonly, I think we see inhibitors. So here's a scenario, patients on apixaban, 5 BID, and they get prescribed. In fact, I think you and I had a case report a few years ago.
Yes.
Rivaroxaban. The details are a little bit vague to me, but the guy was put on clarithromycin.
Yes, correct.
Antibiotics are a great place to focus our energy because we drop those into patients for medicine regimens all the time. And so I don't remember the details, but the guy was on rivaroxaban. He got put on Clarithro for some reason. He had an intracerebral bleed. Is that right?
Yeah, I was on respirology at the time and it was like 2 a.m. and I was seeing this consult and we were consulted because he also had hemoptysis and he was in the ICU. I think we were working together, and that's the only reason why I vaguely kind of knew about this. But I remember emailing you at like whatever godforsaken hour. I was like, hey, Dave, I just saw somebody on rivaroxaban and clarithromycin. Could there be an interaction here? And you're like, yes, send an anti-10A level. And we did.
Yeah, so what happened in that case was we don't use a lot of Clarithro anymore, but Clarithro is an excellent example of a drug that inhibits the enzyme, again, cytochrome P453A4, CYP3A4 for short, that metabolizes rivaroxaban. It also inhibits this pump PGP. And so it's predictable. If you got a patient on rivaroxaban and you give them clarithromycin, you will see a substantial increase in rivaroxaban concentrations and anti-10A activity. Totally predictable and inherently avoidable. More commonly, you'd see verapamil or diltiazem or amiodarone. These are often co-prescribed with DOACs. They're not as strong inhibitors as, say, Clarithro, but got to be careful with them. So with apixaban, for example, someone who's on verapamil, diltiazem, or amiodarone with apixaban, we generally reduce the dose, right, from 10 milligrams twice a day to 5 milligrams twice a day, or what have you. You can see we're getting pretty deep into the weeds. It's a vast topic, and how you approach this depends on which DOAC you're on and which inhibitor or inducer you're talking about. So it's not as cut and dried as we've made it sound, but the point is that there are lots of interactions lurking out there with commonly used drugs that are co-prescribed very frequently. And those are some of the main ones, I would say, with the DOACs.
Yeah, I like that because of the overlap, whether it's because this person also has AFib and they're on amio or DILT, or they showed up to, acute care and got an antibiotic, such as clarithromycin. I feel like antibiotics are the next place we go on this journey.
Yeah. And there, I think the single best example is sulfamethoxazole trimethoprim. And this is also one that you and I studied together, I think, some years ago. You had a paper in BMJ. Is that right about this?
Yeah, that's right.
Yeah. So this interaction, the brand names here are Septra or Bactrim, depending where you practice, but TMP, SMX, the two drugs, these two antifoliate agents that are widely used in combination. Although in the UK and perhaps elsewhere, I think it's just trimethoprim, which is the culprit here. So trimethoprim, it's not widely appreciated. It is a potassium-sparing diuretic. Right? And that sounds like a crazy thing to say, but it's true. If you give human volunteers trimethoprim, you will see them increase their urinary output of sodium and water along with it. And the reason it does that is because it inhibits a channel in the distal nephron called the ENaC channel, epithelial sodium channel. And so that channel, when you block that channel, you put out a bit of sodium and water and you retain a bit of potassium. That's not normally a problem for most people. But if the patient is on another drug that inhibits kaliuresis, inhibits elimination of potassium, then you can quickly find yourself in a position where 1 + 1 = 10 in terms of the risk of hyperkalemia. This is a pharmacodynamic interaction. Trimethoprim is not doing anything to your ramipril levels or to your spironolactone levels, but they are having similar effects on your body's ability to eliminate potassium. And so the question is, who do you have to be most careful when starting trimethoprim in? So you could actually pretty easily come up with a list of criteria that would make someone a high risk for hyperkalemia. They're on an ACE inhibitor or an ARB and or spironolactone, or they've got renal insufficiency. They got a creatinine clearance of 20, 25 mils a minute, on a good day. Or they've got diabetes. Diabetes is associated with a distal RTA, type 4 RTA, and that's an independent risk factor for hyperkalemia here. So the sitting duck is the patient who's on an ACE inhibitor, diabetic nephropathy, they've got a creatinine clearance of 30 mils a minute. For some reason, they're on spironolactone for their bad LV. And they come along with this well-intentioned prescription for Bactrim or Septra for a UTI, and then the patient doesn't show up for the next appointment. So, and that's a tough one because they can die as an outpatient. So I think you showed, if I remember correctly, you did a case control study, and if I remember, it was something like in patients on ACEs or ARBs, when you prescribed Septra, I'm using the brand name, Septra Bactrim, trimethoprim-based antibiotic, the relative risk of being hospitalized for hyperkalemia in the next 2 weeks was somewhere around sevenfold higher than if you'd given them amoxicillin, which doesn't have this problem, right? Is that more or less right?
Yeah, and I mean, I was in R1, so let's be honest, this was all you, and I was along for the ride. And, it was looking at sudden cardiac death as well, and like having access to the sudden cardiac death data. And that was like oh gosh, because to your point, if grandma or grandpa dies at home suddenly, is there necessarily going to be an autopsy? Is there necessarily going to be an exact reason for the cause of death?
No, and if there was an autopsy, it wouldn't find the cause of death here. So, in fact, we've done several studies of this. And so, whether it's with spironolactone or an ACE or ARB, there's a huge increase in the risk of hospitalization for hyperkalemia in the next couple of weeks. But there's also a small but appreciable and statistically significant increase in the risk of sudden outpatient death. And I think it's fair to speculate that I think there are people out there dying suddenly because of antibiotics. It's easy for hyperkalemia to go unrecognized as in an outpatient. So yeah, I think that's actually a particularly dangerous one. Other antibiotics, I mean, what else? We use a lot of, thankfully, beta-lactams, they've got some interactions, but not too many. Probably not worth pursuing. Quinolones have a variety of interactions, and they kind of interact differently. One thing actually to be wary of, the absorption of quinolones, and in fact, many tetracyclines, is really impaired when they're taken with calcium or magnesium, any divalent cation. So this is a pharmacokinetic interaction. What's happening is the ciprofloxacin or the tetracycline is complexing in the lumen of the gut with calcium, and that can really dramatically reduce the absorption of ciprofloxacin, depending on the scenario, maybe even to the point of therapeutic failure. This is an excellent example, by the way, of a drug interaction that you can just get around. Give your ciprofloxacin at 8 in the morning and give your calcium carbonate at 10. Your cipro has been absorbed. It's a bit complicated, but you can easily get around it just by separating the drug's administration in time. Yeah, what else?
I mean, that pearl of, separating in time, I think, other mitigation strategies. I feel like that's a really good one. What are some other common mitigation strategies that you recommend? I mean, you've scared me enough on TMPSMX. I just try to avoid it whenever I can. But what else do you got?
Okay, so I think this is probably the most important thing because people are going to be, I've probably scared somebody with the scope of these interactions and how easy it is to really hurt people with well-intentioned therapy. Drug interactions are inherently avoidable. If you're my patient and I give you a prescription for amoxicillin and then you develop hives and bronchospasm and hypotension and neither of us knew that you had an anaphylactic reaction to penicillins, that wasn't avoidable. But at least, in theory, these are all avoidable. And what's the best way to do that? A couple of ways. One is make sure the patient always goes to the same pharmacy because pharmacies have software programs that when the patient's on ramipril and the pharmacist enters the new prescription for sulfamethoxazole trimethoprim, there will be a flag. And the pharmacist will then have to confront this warning about a potential interaction, and they might contact the doctor to get a different antibiotic, but who knows? They might have some monitoring in place. The point is that the pharmacy computer software, while it's far from perfect, is much better than the human brain. And so
Right.
going to the same pharmacy consistently is the way to go here. If you get your drugs at different pharmacies, you have circumvented that sort of very useful defense mechanism. I think an informed patient's really helpful, right? You said that you're on cyclosporin for your transplant. Okay, before you take anything else, cyclosporin's got loads of drug interactions. Before you take anything else, check with me or check with a pharmacist ideally to make sure that it's safe to take the cyclosporin. I'm not sure how many pharmacists listen to your podcast, but I was a pharmacist before going into medical school. And I think we pharmacists just have more education on drug interactions than doctors do. They have the resources to sort of know how to sort things out. And so having a good pharmacist to go to, I think, is actually pretty critical. A few other minor points. There are some important within class differences. Here's a common class of, let's take SSRI antidepressants, very commonly used. A couple of them, citalopram and escitalopram in particular, cause QT prolongation. And so if I had a patient on methadone, another drug that is seeing more and more use and causes dose-dependent QT prolongation, and that patient needed to be on an antidepressant, I think you would preferentially avoid drugs that cause QT prolongation because there again, 1 + 1 is 5 or 10, depending on the effect on the QT. So you could use a different agent. One of the mitigation strategies here is deliberately choosing a drug from the same class that has a different interaction profile. So those are some of the key ones, I think. And finally, you want to use extra caution with the high-risk drugs, right? Let me give you an absurd example. Patients only on pantoprazole, and you gave them a drug that somehow increased pantoprazole concentrations tenfold. Nobody cares, right? No one's going to die. The gastric pH is not going to go to 14 and eat a hole through their abdominal wall. There's no harm from this. But if the patient's on a calcium channel blocker or immunosuppressant or a sulfonylurea or a statin or a DOAC or warfarin, those are drugs that you don't want to mess with. And tight therapeutic ranges or drugs where toxicity manifests fairly easily. So I think you want to be especially careful when starting a new drug, and especially when starting a new drug in a patient who's already on a drug that you have some respect for. And I think, immunosuppressants, not very common, but good examples there. I think DOAC's probably the best example. So when you're starting a new drug in a patient on a high risk drug to begin with, be especially careful and reach out to your pharmacist in that instance in particular.
Yeah, I like that. I think at some point you also gave me the pearl of, if you didn't, I'm at least giving you the credit for the past 8 years I've been in practice. There should be a short list of drugs that when you see it on a patient, it should probably trigger you to look something up, right? And I think some of those are they on a DOAC? Are they on warfarin? Are they taking TMP SMX? Are they taking cyclosporin? And there's a handful of other medications like amiodarone as well, but I quite like that. So, a summary, what did I learn today? What did the listeners learn today? Okay, so, we started with what is a drug interaction and really the idea that it's really one drug altering the response to another drug. These can be pharmacokinetic, where the drug level actually goes up, or pharmacodynamic, where they do not. We walked through a few examples. We started with good old warfarin, to realize that warfarin plus acetaminophen equals increased INR. We then continued with blood thinners, now to DOACs plus aspirin. Again, this is an example of pharmacodynamic. The levels aren't going up, but the patient might be more likely to bleed. And then some pharmacokinetic examples. Rifampin, where the DOAC goes down. Clarithromycin, where it can go way up. And we continued the journey on to antibiotics, the big one being TMP SMX, and thinking about hyperkalemia, especially combined with other drugs. And then you snuck in a few extras towards the end as well, like the cyclosporin one. I didn't know about that. SSRI plus methadone equals prolonged QT. That was a good reminder for me. But Dave, how do you keep these all in your head? And there's so much hype related to AI. I'm still waiting for a really good use case. Is there like a Juurlink meets large language model so we can actually focus on the more high-risk ones, or what are you using?
Yeah, I mean, I think about drug interactions more than is healthy, and I've done it for a long time. It's going to sound weird. I just accept the fact that I'm never going to be able to keep on top of it all. And I do what you sort of summarized. I have high-risk trigger drugs, high-risk sort of baseline drugs, and I try to devote my energies there. But I have a low threshold to call my friendly neighborhood pharmacist. and I make sure the patient goes to the same pharmacy, because if you do those things, you've got the drugs that the cardiologist prescribes and the psychiatrist prescribes and the internist prescribes, they're often very different sets of drugs. So, if you're a cardiologist, you don't maybe care so much about the interactions with trimethoprim, but if you're an internist, you certainly do. The summaries that you talked about, that's probably the best, until AI has advanced to a point where we don't need podcasts like this anymore. I think that's a pretty good strategy.
Yes, and listeners, be aware, this is all human-generated content, okay? Yes, you can clone voices with AI, but this was old-fashioned, two people sitting down and having a conversation. Well, Dave, it's been great to connect, and it's been great to continue to learn pearls from you. Thanks so much for your time.
Happy to do it. Thanks.
The Rounds Table is hosted online at medicinepods.com, your one-stop source for comprehensive internal medicine education and evidence-based medicine resources. We can also be found on all of your favorite streaming services. You can also follow us on Instagram, LinkedIn, and X. And special thanks to our audio editor, Tamara Van Bakel.